So good afternoon, and thank you for joining us for the second session of the 2023 Winter Spring Third Age webinar series. The Third Age Committee was created in the late 1990s by health and human service professionals from across New York State, and we are committed to advocating for and spreading awareness of the needs of older adults with intellectual and developmental disabilities, or IDD, through educational activities. My name is Laura Robinson, and I am the current chair of the Third Age Committee and the program coordinator for the Finger Lakes Geriatric Education Center at the University of Rochester in Rochester, New York. So just a couple housekeeping items before we begin. There are two very important buttons on your Zoom toolbar. Please use the chat button to say hello, introduce yourself with a name, job title, agency, location, whatever you'd like us to know about you. We have people from a couple different states in the United States joining us today, so we're thrilled to have you all here with us. And then the Q&A button will allow you to type in a question for the presenters. We ask that you use this button at any time during the presentation to ask a question so that the question doesn't get lost in the chat. And we will definitely leave time for questions at the end of the session. Today's session, as you can see by the slide on the screen, is Oral Health is More Than Clean Teeth, and it features Dr. June Sadowsky and Dr. Cameron Jeter. And our moderator for today's session is Dr. Kathleen Bishop. So I'm going to introduce Dr. Bishop to you now, and then I will turn the program over to her. And Dr. Bishop amazingly has over 40 years experience in the developmental disabilities field. So she is a gem and an asset, and 20 as a gerontologist with a specialty in aging with developmental disabilities. She has a bachelor's and a master's in special education and a doctorate from Syracuse University in aging with disabilities. And she is a founding member of the Third Age Committee. Dr. Bishop works as a consultant for many organizations in the aging and IDD networks and assists with program and support planning, as well as teaches at Utica College online courses in aging and disabilities. She is retired from both the University of Rochester and the New York State Office for People with Developmental Disabilities, but that has not slowed her down. She is still super busy and contributing to our field. She is the co-chair of the National Task Group Education and Training Committee. She is the vice president for the National Task Group and co-chair of the advisory body and a member of the executive and the board. And she has been an active member of the NTG since its inception. And I will now turn the session over to Dr. Bishop.
Thank you, Laura. It's just a joy that I have in this field that not only am still able to contribute, but still able to be with all my friends and continuing to make new friends who have the same passions. One of the projects I'm involved in through the National Task Group is with the University at University of Texas at Houston, the Dental Medical Center. I'll have to let June and Cameron give the correct names. I always get it wrong. June and Cameron are both part of our team where we are working with one grant to develop telehealth for underserved populations of people with ID and their families, as well as a secondary or collaborative grant on law enforcement and working on helping make sure that people in the IDD field are connected to law enforcement and looking at ways to reduce some of the tragic issues that happen when they do come in contact. It is my pleasure to introduce my team members and friends, Dr. Cameron Jeter, who is a cognitive neuroscientist with expertise in clinical and translational research of oral health and neurological disease. Dr. Jeter is professor at Kansas College of Osteopathic Medicine. She is also a member of the American Academy of Developmental Medicine and Dentistry, speaking and advocating for adults with intellectual and developmental disabilities in annual meetings, webinars, and local chapters. Additionally, it's my pleasure to introduce Dr. June Sadowsky. She is one of the few dentists countrywide and actually internationally to have completed a fellowship in geriatric dentistry. She is professor at UTHealth School of Dentistry and leads curriculum and research in geriatrics. She is also dental director at Richmond Living Center in Texas for individuals with intellectual and developmental disabilities. She is a founding member of the Houston Geriatric Education Center, funded by HRSA, and is a member of the executive committee of the UTH Consortium on Aging. Again, I've learned so much from both of them, and I'm excited for all of you to learn from them. So thank you for joining us today, and thank you, Dr. Jeter and Dr. Sadowsky.
Thank you, Kathy, Dr. Bishop, for inviting both June and I to share some of our expertise and what we've learned. And I'll say, as a non-oral health professional myself, one of the first things I learned a decade ago as a new faculty member at a school of dentistry is simply the title of this talk, that oral health is more than clean teeth. And so I want to dispel the myth that all we need to do is brush our teeth and all that we see on our teeth, if it's clean, we're good, so that we all learn together truly the importance of oral health. And a bit of a foreshadow is that how that is affecting our overall health and our long-term health in all aspects of our life. So I first want to share the 3 different learning objectives that we have with our time together. First, we will define different components of oral health. We'll move on to talk about the bidirectional relationship between oral and systemic disease. This means how good oral health can encourage good overall body health. And then lastly, we'll wrap up with some practical tips so that you, the participants, can develop better skills to help others, particularly older adults with intellectual and developmental disabilities, do daily oral hygiene, whether the adult does it for him or herself or their caregiver helps in that process. So I'll turn it over to June, Dr. Sadowsky, who will talk about how we take oral hygiene for granted.
We certainly do. Of course, we've all been brushing since we were young. And who did we learn how to brush from? But our parents. And so that sets the stage for how many times we brush per day, how long we take to brush. You know, it's said that you're supposed to be able to sing happy birthday twice while you're brushing. So if you mentally sing happy birthday, that's the length of time you really should be brushing. Next slide. And so we're always looking to see if we have food in between our teeth, looking at our oral health, checking our breath, just like this says. So, you know, we're all interested in oral hygiene. And the Federal Dental Federation of the World stated that oral health is multifaceted. It includes not only swallowing, chewing, all of the emotions of facial expressions, how to speak, how to smell, how to taste. So it's a very complex part of our body. So what are the physiology of oral health? We're going to go through hard and soft tissue, what the structure and function is, and what's both visible and invisible. So the mucosa, which is the lining of our soft tissue in our body, the oral cavity, the GI cavity, urinary and reproductive tracts. And it has 3 layers, and it's a epithelium, and it has a supporting lamina propria and a layer of loose connective tissue. So underlying that is the submucosa, consisting of dense, irregular connective tissue and the minor salivary glands. So we might have some adipose tissue in those regions, but the mucosa is bound to either bone or muscle. So that's important to know. The tooth, I believe it's the next slide, consists of crown, which is the top part that peeks out of the gums, the pulp chamber, which has the nerves, one or more roots, which contain those pulp canals, and the outside of the upper part of the tooth is covered with enamel. That's the hardest biological substance known. And it is the portion that lives in the oral cavity. So we have grooves and areas where there's places for plaque to form, and where we have where the root goes down and is encased in bone. And this is what the actual microscopic area of the areas of the soft tissue around the tooth. The soft tissue can turn over. It revitalizes itself every 3 to 7 days. So when you brush your teeth and they might bleed, then on the next time you brush, it gets better, it gets healing. So if you continue to brush, within 3 to 7 days, there will be no bleeding, because you will have built up satisfactory tightness in your gums, and they will be healthier, because it's the plaque that causes the gums to bleed, because the gums are trying to take that away and suck it down into the bloodstream, which if we keep it off, it won't have to do that. So let's look at teeth, how they can change whenever they age. You know, the outside layer, the enamel hardens and it gets more yellow as we get older, and it could result in cracks and microfractures. The second layer, which is called the dentin, lays down more secondary layer as we age. So the tubules are closed off. You can see how there are lines started going out to the edge of the tooth from the nerve. The pulp chamber, which is in the center where the nerves lives, increases with deposits of secondary dentin, and that makes there be less pain from cold or sweets or whatever reason. You have less pain in your teeth as you get older. So the cementum on the root of the tooth can decrease the conduction of heat and pain and cold. So that sort of the old tooth is more protected than the younger tooth. Let's talk about the function of the oral structure. We know our jaws, our tongue, our teeth, our lips aid in communication. And we know that the lips and the tongue and the jaw aids in swallowing, because as we chew the food, our lips and tongue mold the food to be swallowed. Our teeth and lips control chewing and mastication, eating. Our tongue, saliva, and the pharynx hold the key to taste. So that's in digestion. The saliva helps us taste it and digest it. As you can see on the right-hand picture, there are a few opposing teeth, and it's very difficult to masticate when you don't have teeth that match up. It's very important to have biting pairs. So if you see someone with teeth that are like a jack-o'-lantern, you know that they aren't able to really chew their food. Okay, let's look at the salivary glands. That is one of the most important parts of the oral structure. And you can see when there's no saliva, your mouth gets very sticky and dry and becomes sore. And it's very difficult to eat, and it's very difficult to speak. And your taste is altered. So when one thinks that it's just, you just increase drinking and it'll be okay. But that isn't true. It could help, but there is an increased sense of thirst, and it gets more difficult to swallow. So without the good effects of saliva, the plaque accumulates around the teeth, and it can decay on exposed parts of the root. So we need to have a salivary gland function in order to be able to chew and eat well. One also may get sores in the middle, in the corner of your mouth. And that medications that we take, over 300 and some odd medications that older persons take, can induce dry mouth. So the effects are both visible and non-visible. Let's look at that slide. Look at that. We can hold a light behind the tooth. That's called transillumination, and it shows that as we get older, we get little fracture lines in our teeth. You can see it going up and down on this lower right-hand picture. On the left is under normal light, how we see the tissue in the mouth, and on the right is a special light. It's a phosphorescing light, which is a certain fluorescence, a certain wavelength. Starts out blue, but then it reflects back green, and it reflects areas where there's a large blood supply or a large nuclei, or areas that are potentially cancerous. So this is used to detect these oral lesions and cancer. So it's a very important part of the invisible part of the oral cavity. Let's look at the saliva. You can see on the left the places that we have the glands that moisturize our mouth. And as you can see, that we have parts that digest the food. That's called the amylase and lipase. We have buffers, meaning that we keep it in the range of 7.0, because that allows for the acids which want to eat into your teeth from drinking sodas or drinking orange juice or something that's acidic. Then as our saliva brings us back to normal, it remineralizes and helps protect the tooth. There are lysozymes and immunoglobulins, that's a misspelling, have antimicrobial activity. The mucins, which are the lubrication, and they protect the membranes, make it so that food falls around on it and you're able to swallow it. There are over 300 protein types, peptides, and electrolytes that are microscopic contents of the saliva. Let's look at the next. Oh, that was yours. I'm sorry. Go ahead, Cameron. I'm sorry, I didn't look down. Apologize.
Well, we both are so excited about this topic, and I'll say that as the basic scientist, or the one who studies oral health in the laboratory and in the clinic, I am interested in this visible and invisible component. Invisible we put in quotations because what we're meaning is that these structures that we see either by the fluorescent light that Dr. Sadowsky presented a few slides prior, or, for example, oral bacteria on this slide, they're not truly invisible, but they, in a sense, are unseen to the naked eye. So, for example, this black and white image on the right is taken with an electron microscope, zooming in many, many times magnification for you to see the different shapes and sizes of bacteria. What's further fascinating to realize that there's bacteria in our mouths is that science has shown us that we can expect certain species of bacteria to live in different crevices and on different structures inside the mouth. That's what the figure on the left is depicting, is that we have certain types of species that we know would grow on the hard tissue or the tooth itself, and a different set that would grow on the soft tissues, like the inside of the cheek, or on the mucosa of the hard and the soft palate, and even yet another group that would live on our tongue. This isn't just by chance. It's because each of these colonies and communities of bacteria help with the motility, meaning moving food and particles and plaque through the mouth, keeping the saliva at the right acidity, etc. And so how does it do this on the microscopic level? I want us to look here on the left, seeing that the brown ovals are indicating bacteria, individual bacterium. They attach to the surface, and they do this in health. The surface may be soft tissue, or it may be the hard tissue of the tooth. At the beginning, this pile, as it grows, feels slimy. And so you might know how, as you run your tongue along your teeth several hours after brushing your teeth, it has a slimy covering. That's not just your saliva. In fact, that's the beginning of a biofilm, basically a blanket of bacteria growing. But you notice over time, if we don't brush and clean not only our teeth, but the soft tissues of the mouth, this biofilm can grow and stack into almost rock crystal towers. They're shown in yellow on the far right of the figure, where a mature biofilm is actually a dental plaque that we might see as white, but can even thicken and harden over months to become calculus. Calculus being plaque that is hardened and can only be moved and removed with oral hygiene care at the dentist. So as we know about these biofilms, what they can do is change a healthy tooth on the far left to be one that has not only dental plaque, but perhaps also dental decay and create cavities. Microbiologists working at dental schools and the like have been able to decide and know which types of bacteria and families of bacteria are considered healthy or disease type. So in this figure, the gray box in the lower right, you can see that there's certain groupings of bacteria that we color in happy colors of blue and yellow and purple. These are oral bacteria of health. But as you transition rightward across the figure, you can see that there are what we call red complex bacteria, P. gingivalis being a big culprit of gingivitis and the eventual disease called periodontitis, where the gums and the ligaments attaching the bone to the teeth loosen and your teeth can fall out. So this microbiology to me is just fascinating. It's the invisible component of oral health that we wanted to present. So we've covered our first learning objective, namely to define different components of oral health, where we learned about the difference between hard and soft tissues of the mouth, and then there at the end, visible and invisible components of oral health. I'm going to continue with us in objective 2, where I talk about how oral health can be linked to systemic health, how, in a sense, keeping good oral health can ensure better overall health. And likewise, in the reverse direction, how if we have a systemic disease, for example, type 2 diabetes, it puts us at higher risk of oral diseases. In that case, gingivitis and periodontitis. So here is a flyer that we've digitized and put on the slide to actually let us know all the plethora of diseases that are body diseases linked to gum disease. So you can look across the list and see that osteoporosis could be a higher risk for people who have gum disease, as well as a stroke. It's been shown that people in midlife who have periodontitis, that's a severe gum disease, are at higher risk later in life of having Alzheimer's disease or another type of dementia. Cancer, respiratory disease, and even heart disease have been linked at higher rates to having an oral disease. And as I mentioned already, diabetes and an additional one of rheumatoid arthritis. Each of them have a different molecular reason why they're linked to oral health. But by looking at epidemiological data and other clinical studies, we know that there's a propensity for these to be related to one another. In science, of course, we can look to the medical literature to confirm that this is true. And one of the most strong types of medical papers is called a systematic review or a meta-analysis. These types of papers actually are a summary of many research studies. This figure is from a systematic review paper trying to visualize all the different research studies that across the top studied oral diseases like periodontitis, tooth loss, or caries, caries being the dental term for cavities, and then linking those to the diseases across the bottom that we would consider systemic or overall body diseases. So you notice in the green square, there were 88 systematic review papers of periodontitis, and 51 of those were linked to papers of diabetes type 2. In a sense, we just look at the thickness of the line connecting the top oral diseases to the bottom body diseases, and we can see the strength of a relationship. This means that there is the most data to support that periodontitis is highly connected to body diseases like diabetes, cardiovascular disease, and less so to these other 5 of cerebral vascular disease, COPD, dementia, psoriasis, and lung cancer. I think this is a shocker to most of us and is a real motivator to keep up with our oral health. So I mentioned that there's different mechanisms for how body diseases are connected to oral diseases. This figure is just to emphasize a few of them, that if we start in the far left panel in blue in the periodontium, this is in our gums, between our gums and the roots of our teeth. Here is the home of bacteria. As I mentioned, in health, this bacteria is healthy and serves a good function. But without good oral hygiene, this bacteria can form biofilms and different colonies that become those red complex bacteria, eventually even joining the blood circulation, that middle panel. So it breaches the barrier and gets into the systemic blood flow, going to distal sites in that yellow panel that could be any of the other organ systems in our body. And so this is how inflammation spreads throughout the body and is the underlying theory for how oral disease can impact overall health. I'm going to pass the slides back over to Dr. Sadowsky as she'll walk us through some of the specifics of the risk between oral health and overall health.
The main one that you saw had the biggest impact was diabetes. And they know that because of the studies on the right, that whenever you have an HbA1c of greater than 9, you are 3 times more likely to have periodontal disease that's very severe. So that's poorly controlled, anything over 9. And we know that 1/3 of diabetics have severe periodontal disease and have lost their attachment. So that means their teeth look longer, getting long in the tooth. Diabetics don't heal well and have higher rates of their implants failing. So we know that we have to keep our mouth very, very clean if we're a diabetic so that we won't have any of these problems. We know that if you have treatment, if you have your teeth cleaned more often at the dentist, that you can reduce your HbA1c by 0.8%, nearly a whole point to make your diabetes more healthful. And not only with people with diabetes more susceptible, but it can make it worse and by affecting really poor glucose control. Next one. Okay. Like also cerebrovascular and cerebral cardiovascular have a definite link to gum disease. And there is epidemiological evidence that future cardiovascular disease is risky if you have periodontitis. And we know that the reduction after periodontal disease is periodontal treatment shows it reduces the markers, meaning those inflammatory markers that are indicative of cardiovascular disease. So, and dementia, they have increased the likelihood of dementia with deep pockets and poor oral hygiene. And we have increased plasma levels of inflammation antibodies. And I know that the highest IgG to P. gingivala is more likely to have poor verbal recall and subtraction skills. So they have actually, these are actual studies that indicate how dementia is affected by these inflammations of periodontal bacteria. So we want to look also at how our quality of life is dependent. Self-esteem and self-perceived dental problems are correlated to oral health. And we know poor oral health with low lifestyle activity is also linked to poor oral health. So if we increase our lifestyle activity and our self-esteem, we will have better oral health. So successful aging very definitely depends on oral health. And this gentleman on the right is age 100. And look how many teeth he has and how they're all biting pairs and how he looks, his teeth look great. Whenever you have missing molars, there's an increased risk of premature death if you have periodontitis and have lost molars. Kaufman in 2014 saw that if there was less edentulation, meaning less loss of teeth in a centenarian, 100-year-old birth cohort, that they were healthier oral wise. Children of those centenarians had better oral health than the reference cohort. So it really does mean that successful aging depends on oral health.
Thank you, June. So we've seen very clearly how the research links oral health to good overall health and longevity. And so now we're going to move into our third and final section, which is perhaps the boots on the ground practical advice on, okay, so how can I maintain my own oral health and that of my loved ones, particularly those who are adults with intellectual and developmental disabilities? Because as we all know, someone coming at you with a toothbrush is not a pleasant thought, especially when you don't know the intent or the importance of this. And June, as the expert dentist geriatrician, has some practical tips for us. And it's even been a national call to this oral health practice from our U.S. Surgeon General, saying too many people outside the oral health community are uninformed about, misinformed about, or simply not interested in oral health. So we hope that we've motivated you to be interested in oral health and now ready to learn what to do. As we have made the case that oral health gives better overall health, we hope that you'll also believe that having better oral health can help save medical costs. So here, saying that if we can keep our loved ones out of the emergency room because of dental abscesses or other dental pain, we can be saving quite a bit of money, not only for insurance companies, but for individual families. And it's not just about oral pain and those conditions seen by a dental professional. The bottom paragraph there is reminding us that having bad oral bacteria can be a source of pneumonia. And so people, particularly in the hospital on a ventilator, can get aspiration pneumonia with additional medical costs yet to come. So I'm going to turn it over to June, who's going to talk about, from her perspective, why we need an interdisciplinary approach to oral health.
Interdisciplinary help has been very important to me during my career, and many older adults have to choose between oral care or systemic care, and that shouldn't be. We need to make a place in the medical home for oral health screening and guidance, and to help by not just looking at the pharynx, but looking at the oral health of the person that physicians see. And we would be willing, I know Dennis would, to include medical screenings chairside, and we can help people achieve better oral health if we all work together. So I want you to be aware of any medications oral side effects. There are many of medications, like I told you before, about how certain medications can cause dry mouth. And sometimes even the changing from one class of drug to the other can alleviate that. So it's worth the physician thinking about when a patient says their mouth is very dry, or even asking the patient if their mouth is very dry to alleviate that. Any condition that's going to affect how we do our oral health is a detrimental impact. And any infection, intraoral infection, as a possibility to screen for what other things might be, and to refer to the family dentist. So let's look at some ways we can help. And we know that we take care of our loved ones, and it's always great to help them by show, tell, and do. We want to help them by telling them what we're going to do. We're going to help them brush. And it's always better to stand behind a person and even give them a hug before you start, and let them know what you're going to do, and with a hand that would stabilize their head so that you can do it. You must have a really soft toothbrush. I've noticed that some people say, oh, that toothbrush hurts. Well, if the toothbrush hurts when it touches your gum, it's too hard or it's too dry. So I think that we need to look at our implements that we're using to brush. And you want to model it. You want to show them the correct way to brush in a circle for each tooth rather than side to side. So if we approach from the upper side and move to the upper right, lower right, then outside, then inside. We do the biting surfaces and the tongue, because the tongue on everyone needs to be brushed daily. We want to use cocoa butter because we can't use Vaseline because it degrades our gloves. And so we want to use lip balm or cocoa butter containing ointment. We want to make sure that your toothbrush, they're getting toothbrushes that are so big, have plastic in them, rubber in them, and it's just not comfortable for tender gums. So you want to have one that's recommended for periodontal treatment or is considered very soft. A battery-powered toothbrush can help a lot in people who you want to make sure that they have the care of doing their own brushing, because the battery-powered toothbrush can do the circular motion by itself. We can adapt the toothbrush by putting a piece of foil on it, or tie a washcloth around it, or even with a bicycle grip. We know that we must brush before bedtime. That's essential because it takes all of the night and all of the bacteria growing and partying and having fun. So we need to make sure that we brush before, so that's the lowest amount of bacteria. And we want to do it so it's fun. We want them to be either listening to music or watching TV, because we know that they're more relaxed, and that's the best time. We don't want them to be tense. Okay, if a person wants to bite on the toothbrush, we have to find a way to prop the mouth open. There are many things that we can buy to help keep the mouth open, or we can just take a gauze wrapped around a tongue blade, and that can help prop the mouth open. Gums that are brushed effectively do not bleed, and we need to remove all that harmful plaque. And we need to use fluoride. We need to use fluoride toothpaste. And if we have cavities when we go to the dentist, we need to increase our fluoride by having prescription fluoride. Fluoride is really the answer. And we just used to think it was just for the young, but it's for everyone. And we know that dry mouth, the dentist can help advise, because we need to have a moisturizer, to put in the mouth to help alleviate that dryness.
I'm pausing, June, because I'm looking at the chat box. And Kathy has suggested that we pause and respond to Dr. Frederick. I don't see your last name, sorry there, but he made the comment that he once worked with a patient whose periodontal disease was so serious that the patient required a mitral valve replacement. So I wondered if you might comment, June, on the frequency you've seen that in your practice, or maybe what the causal link might be there.
Well, like we were saying, it is directly linked to heart disease, and to have what happens is whenever that bacteria get into the bloodstream, we're pumping it through our body and through our heart, and some of them stay on those leaflets in our heart, and that is it causes that valve to not work, and it causes blood to slip through. So I think that it's very important that person probably has no idea that that's really what that his poor old health caused that. But if he had his teeth all taken out, he wouldn't have that much bacteria to continue to help his leaflets get so that they're floppy.
And I'll say even the converse. I know patients who might have a congenital heart disease. This is one of the reasons they're advised to take an antibiotic before they would have a major dental procedure that might cause blood in the oral cavity, of course, and breaking that barrier to enter the systemic blood flow.
Exactly. We want to make sure that we keep our oral cavity as clean as possible, because it goes into the bloodstream, and it can go several different places, just like you said.
All right, let's go on to see here we're coming to the very end. I'll just remind us that the U.S. Surgeon General went on with his encouragement of the nation paying attention to oral health, saying it's essential to general health and that we all should be taking action. We need collaborative efforts so that we have understanding across all medical professionals, so that we can accelerate science translation to benefit those with the poorest oral health or at greatest risk, which is our vulnerable populations. So we, of course, have several slides of references if you're interested in those details, but we've come to the end of our formal remarks, and we would love to have either questions that you pose or even sharing some more stories of personal experience with the link between oral and overall health. I'll mention the hope that we get into conversations of particularly adults with intellectual and developmental disabilities, and how some of their what would be called behaviors are thought to be belligerent or obstinate behaviors, when frankly they're just trying to communicate pain, and we should not exclude from consideration oral pain, even grabbing at your face, beating your head. From the neuroscience perspective, me being the brain scientist, I'll just mention that the areas of the brain that acknowledge sensation, whether that's pain or temperature, they are a larger surface area for the face than other parts of the body. This is why oral and facial pain is disproportionately so adversive than maybe just something on the back of your calf that you don't even notice that you got a nick while you're out hiking with your family. But anyway, thank you so much for your attention. I'll pause there as I promised and wait for any questions or comments.
Thank you both so much. I think Kathy is still with us, but this is Laura, and I just want to
Yes, I am.
interject. I have a couple questions. I don't see any in the Q&A, so I thought I would just go first if that's okay, and give people a couple more minutes to
Then
type
there is
in.
another one after you do, Laura.
Okay, so we know with a lot of older adults, they're on a lot of medications. A common side effect of medication is dry mouth or the xerostoma. And as people get older, they're often incontinent. So that's a problem with water intake. So how do we balance this coming together of all of these symptoms together to prevent dry mouth, but also not have people be uncomfortable and going to the bathroom more than they need to keep their mouths moist?
Well, I really feel that you don't need toothpaste and rinsing your mouth. It's good, but if you just have a soft toothbrush after you eat, I recommend, like truck drivers, hey, you're driving down the road, brush your teeth, because that keeps you awake and it cleans your teeth. So I think that we want to make sure that they have don't have dry mouth, and I think that starts at their physician's office if they do have severe mouth dryness, and to tell their physician about that, because a lot of times the physician isn't even aware, and they come to the dentist and say, oh, my mouth is so dry and I drink water all the time and I have to go to the bathroom all the time. And if we use the moisturizer, it's one made by, there's several made, you can buy them, you know, at the drugstore, and it just squeezes a little bit of that moisture in it. And it's almost like saliva, because it moistens and it smooths, and it makes the tissues feel nice and not dry and sticky.
Thank you. I'll turn it back over to Kathy now.
Okay.
Yeah, we have a comment, and I think it's a question from Kiara, and I'll read it. I recently read that dental studies are showing that brushing 2 times a day is best, but to also not brush directly after eating because your enamel is more susceptible to bacteria. Sorry, I've got to go down a little bit. To bacteria, sorry, and that can actually soften your enamel and interfere with the remineralization. As a speech pathologist, I prefer to have people with IDD to have mouths cleaned after meals to eliminate bacteria and pocketed food.
Okay.
Sorry,
There are two things.
But I found I've got so there's not aspiration, but I found the info about enamel being helpful. I guess, can you comment on that?
Yes, there are 2 things that I would like to say. First of all, is that whenever toothpaste is very abrasive. So if you go in and brush your teeth vigorously with toothpaste, you're actually wearing off some of the enamel. And if you do it right after you eat, you have already, like you've had breakfast and you've had orange juice and you've had a grapefruit, or you've had something more at that meal that's acidic. Your mouth is in an acidic state. And so you brush it with that toothpaste and it does take off the enamel. So it's better to rinse your mouth just with water, or just with water on a toothbrush, to try, because water is actually 7.0 in pH. So it will help return your mouth back to a safe state.
And then June, go ahead and tell us that doesn't get us off the hook of using toothpaste at bedtime.
No, toothpaste at bedtime is good. It helps kill the bacteria, and it freshens your breath. So I would say at bedtime is a perfect time to use it, because you haven't been eating anything acidic, and your mouth is at its most steady state. So brushing with toothpaste and using the correct way of brushing will help at bedtime. Because all night long we're going to go, and bacteria are going to be partying. So we have to make sure that we have the fewest in there before we go to bed.
So you mentioned the pH of water, June. This is Kathy.
Uh-huh.
Are there any other liquids other than water that will help restore? For example, some of us, like myself, will drink tea quite often during the day. I assume that may have more acid and less of the pH balance.
It is. Both tea and coffee are acidic, and if you have sugar with it, that means that the sugar is on your teeth for a long time if you just sip on a drink. So that's why I recommend water. Now the sports drinks all have sugar in them. The monster drinks, the ones with what do you call it, the high energy drinks, they all have a lot of sugar, and it's just, you might as well be drinking Dr. Pepper. Or I say rinsing with a fluoride rinse is as good as water, but the fluoride rinse is very important.
June,
And you would get that any pharmacist or a drug?
At the drugstore, at Target, at Walmart, anywhere you can buy. It's called fluoride rinse. There's FluorGuard. There's several different brands.
Great. Sorry, Cameron, didn't mean to interrupt you. Go ahead.
Well, I was just wanting June to share another big tip, which I think will be helpful to adults with IDD who already have oral health troubles, but for whatever reason are not good candidates to go to the dentist and maybe haven't gone without full general anesthesia, which as another topic we don't recommend. But I guess I'm wanting you to tell us about silver diamine fluoride and how that could be a solution at their local dentist or even in their home, and how it doesn't have to be applied by a dentist.
That's correct. This is very new on the market. It's really marketed for sensitivity. But what we have found that it does is that it stops decay. So if the person has decay and you want to stop it in its tracks, silver diamine fluoride by the dentist, I think that they would have to either supply it to you, because I don't think you can buy it. That's it. Good. And it will help stop the decay until you can get to the dentist, and it will even stop pain of decay. Like if they're having a toothache and you have that on there.
And it's painted on with a little paintbrush, so it's painless.
Yes, and you don't have to be anesthetized or anything. You just have to say, "Oh, I want to count your teeth," or whatever system you use to have the trust of the person. That is the most important part. If you have the trust of the person and can give them a hug along with it, you can accomplish so much.
There also, Dr. Wetzel, that's Fred's last name, Wetzel, Cameron, has made a comment about reducing anti-chlorogenics. I don't have it in front of me. Can you comment on that, but also on medications and the impact on oral health?
Well, I just didn't want to bring up any specific one, but the anticholinergic drugs are the ones that cause your dry mouth, and several of the heart drugs cause dry mouth. So yes, we can reduce our Zyrtec, and that will help. And we can also talk to the physician about changing to perhaps a less one that's effective for you, one that is effective but not creating dry mouth. But thank you, Dr. How did you pronounce
Wetzel? Dr. Wetzel.
Thank you very much, Dr. Wetzel. You've been a great addition to the talk.
There's also one more question before we close. It's from Judith Gleason. How often should we rinse with the fluoride?
Well, there's a study from a friend of mine that says if you use fluoride toothpaste and a rinse twice a day, use fluoride toothpaste, that can help. Studies have shown that that's helped prevent decay. So, but you have to do other things like cutting down on the sweets that you eat, because we know that the high carbohydrates, that the bacteria just love them. And if that, or ice cream, the bacteria just love anyone who sits at night and watches TV and eats their ice cream. So we have to do our part every day to prevent cavities.
Now that you've ruined my evening treat, June, there's another comment from Karen. Paradex is widely used by our dentists. Is this appropriate?
Paradex. Okay, Paradex is a specific item to kill bacteria. And yes, it's used when you have periodontal surgery, when you have teeth taken out, but it's not to be used more than a few weeks, because it will not only kill the bad bacteria, it will kill the good bacteria. So if you want to make yourself open for all kinds of infection, is to use Paradex for a long chronically, which is more than a month. It's just not for that.
Great, thank you. This has been so informative. I've heard you both many times over the 2 years now, over 3 years now we've been working together. I'm always amazed each time you add additional information that should be taught to us as children, or at least certainly our parents should know about it when we're children, and it's not widely known. So just wonderful. If there are any questions anyone has, they think of after, a way that people can contact you, or do you want them to go through Laura? Or
Hey, I'm just available on the UT School of Dentistry website, and you can send me an email there. Just looking me up. I had a dentist who was having a problem with oral health with one of his patients, and he did just that. And I wrote him back and said, let's talk about your patient. So we talked for a long time. I told him what he could do besides thinking of crowns and taking out the teeth, that he could put the patient on a holding pattern and use SDF, use fluoride, and it could all be done by his hygienist. And it was just like a paradigm shift for him. He was just so happy. I said, you can't ruin this trust relationship that you have with this patient by referring them to someone else. I said, it's more important. If they can't brush, find out who can brush them. Maybe they can hire someone to brush their teeth if they can't do it. Maybe it's their medications. You know, we got to investigate and help this person back to oral health, which we can do.
wonderful, thank you. And Cameron, to contact you with questions?
Yes, I'd say contacting Laura is fine. She has our contact information, because I am both adjunct faculty at the University in Texas, but also full faculty here at a osteopathic medical school in Kansas. So we appreciate your participation today.
Yes, me too.